So my name's Samantha. I work part-time in NHS as a locum doctor. So I work partly in sexual health and partly in obs and gynae. And I spend the rest of my working life writing, editing and lecturing. So I think I've met a few of you guys before from previous lectures. So this lecture is going to be primarily question-based. So we'll cover single best answer questions, which are the main kind of component of Quesmed's questions. I will fire through this fairly rapidly, but as Julie said, it will go up online, so feel free to go back, pause it, go through it again at your own time. So we're going to cover some gynecology topics today. We're going to cover all things menstrual, amenorrhea, menorrhagia, dysmenorrhea, irregular bleeding, postcoital bleeding, do a bit of contraception, emergency contraception and combined hormonal contraception. We'll have one question on hormone replacement therapy. We'll talk a bit about Fraser guidelines. And as always, we'll finish off with an emergency scenario from a real life case. So let's start off by talking about some basic definitions. So menstruation, that's an easy one, that's bleeding. Amenorrhea is when the woman has no periods and no bleeding. Menorrhagia is excessive bleeding. Dysmenorrhea is painful bleeding. Irregular bleeding includes irregular cycles and intermenstrual bleeding. And postcoital bleeding is bleeding after sex or during sex. So let's dive in with the first question, which is related to amenorrhea. I'm going to give you 1 minute to read the question and submit an answer.
Cool, so I'll bring up the poll now, just so sometimes it blocks people's screens if you're not using a laptop, so hopefully you'll be able to see the polls. You've got A to E options. And we'll just give you 30 seconds. Last 5 seconds. Okay.
Great, thank you for answering. So I'm just going to close the poll there. So let's talk a little bit about menarche. So menarche is the occurrence of the first menstrual period, and it usually occurs approximately age 12 to 13 in the UK girls. However, normal menarche can occur anywhere from age 8 to age 15. So before we talk about early and late menarche, let's talk about puberty. So puberty is defined as the development of secondary sexual characteristics. So this is breast development, pubic and axillary hair, and the widening of the hips in females. And this occurs in response to an increase in the pulsatile secretion of LH. Puberty usually happens in a specific order. We normally get breast budding and breast development first. We then get development of pubic and axillary hair, and we then have menarche, which occurs approximately 2 years after breast development. So precocious puberty is what we call the development of secondary sexual characteristics before the age of 8, or the occurrence of menarche before the age of 10. Thinking about delayed puberty, this is the absence of menarche and secondary sexual characteristics by the age of 14. We also talk about primary amenorrhea, which includes the absence of menstruation even with normal secondary sexual characteristics by the age of 16. So looking back at our question, this young female is 16 and she's not yet developed any secondary sexual characteristics. So we're calling this delayed puberty. Now, the most common reason behind delayed puberty is constitutional delay. These cases normally have a family history of mums and grandmothers having delayed puberty. So that's the correct answer. I think most of you guys got that, so well done. Thinking about the other answers, Turner syndrome, yes, that's a cause for delayed puberty. Quite common puberty is delayed in Turner syndrome. However, Turner syndrome has quite obvious phenotypical characteristics. So normally the females are short, they have a webbed neck, broad chest, wide carrying angle. This female is described as normal phenotypically and tall and slim. So this is unlikely. Thinking about the other options, an imperforate hymen and primary amenorrhea. So normally these females have evidence of secondary sexual characteristics. So we'd expect to see something like breast development or hair development. And normally what happens here is they get what's called retrograde menstruation, which is where the menstrual blood simply cannot get out of the vagina. And normally that presents with cyclical pain. Mayer-Rokitansky-Kuser House syndrome, I have never seen this. It's a rare congenital condition where the uterus and the vagina don't develop properly. So these people normally have a blind ending vagina and no uterus or a malformed uterus. These females normally have normal secondary sexual characteristics but primary amenorrhea. And while we should never forget to ask about pregnancy, in all cases of amenorrhea, even primary amenorrhea, the scenario does say that she's not sexually active. So unless you've got any reason to suspect that she's lying to you, pregnancy is not a likely answer. So let's move on to the next question. And again, I'll give you a minute to read the question and submit an answer.
Okay, so the polls should be up for you to vote. And again, 30 seconds for vote. Last few seconds. Okay.
Great, thank you for answering. I'll just turn my video back on. Oh. Thank you for answering. I think most of you guys got the correct answer, which was B, uterine fibroids. So let's talk about menorrhagia. So menorrhagia is excessive or heavy menstrual blood loss, which interferes with a woman's quality of life. For obvious reasons, it's hard to measure menstrual blood loss, but NICE guidelines say that excessive blood loss is 80 millilitres or more, or a duration of more than 7 days of bleeding per cycle. For context, the average blood loss during menstruation is 30 to 40 mils, and 90% of women have losses much less than 80. However, the NICE guidelines also say that it's defined by any heavy periods reported by the woman. So when you're diagnosing menorrhagia, it actually doesn't matter how much blood loss there is. If the woman says she's having heavy periods, she's having heavy periods and she has menorrhagia. So let's talk about the causes of menorrhagia. So in up to half of the cases, there's no cause identified. We can then divide other causes into uterine and ovarian causes, systemic causes, and iatrogenic causes. So uterine and ovarian causes include fibroids, endometriosis, infection, polyps, hyperplasia, and PCOS. Systemic pathologies include things that mess with your coagulation, so any sort of coagulation disorder, hypothyroidism, diabetes, hyperprolactinemia, liver or kidney disease. Menorrhagia can also be caused by us as doctors. Anything that we prescribe that's anticoagulant, chemotherapy, and even herbal supplements can cause menorrhagia. And copper intrauterine devices are a common cause of menorrhagia. So let's talk a bit about fibroids in particular, as they're one of the most common causes of menorrhagia. So fibroids are benign tumours of smooth muscle cells and fibroblasts, which form a solid lump in the uterine myometrium. These mess with the normal vasculature and menstrual physiology. They can vary in number and size, can be tiny and totally unnoticeable, up to massive, greater than 30 centimetre fibroids. Risk factors for fibroids include increasing age, early puberty, obesity, Black ethnicity, and family history. And as we said, the symptoms can be completely asymptomatic. Other symptoms include menorrhagia, pain, dysmenorrhea, and even urinary or bowel symptoms if the fibroids are particularly large and are pressing on the bladder or bowel. On pelvic examination, we can often find a firm, enlarged, irregularly shaped uterus. So if we go back to the question, so this woman is of older age and is overweight, so she's got a couple of risk factors there for fibroids, and on examination we can indeed feel the uterus. So the most likely diagnosis here is uterine fibroids. It's unlikely to be pregnancy with a 4-month history of heavy blood loss. However, always ask about risk of pregnancy. It's less likely to be endometriosis, as this doesn't typically cause a palpable uterus, and usually the primary symptom in endometriosis is pain rather than heavy bleeding. Cervical cancer certainly can present with heavy bleeding, but often the bleeding is unrelated to the menstrual cycle and wouldn't typically cause a palpable uterus unless it was very advanced. And dysfunctional uterine bleeding is a diagnosis of exclusion in women experiencing irregular or heavy bleeding. While 50 to 60% of cases of menorrhagia are due to dysfunctional uterine bleeding, the palpable uterus makes uterine fibroids the top answer. So let's talk a bit more about uterine fibroids. how we'd manage this woman. So the diagnosis should be confirmed with an ultrasound scan. This can be obtained routinely if you've got no worries about cancer or anything like that. If there's any signs that you're worried about, so ascites, weight loss, irregular bleeding, you'd want to urgently order that ultrasound scan. If the symptoms are manageable, we actually don't need to provide any particular treatment. However, the first line treatment is a hormonal intrauterine contraceptive system, so the Mirena coil. This secretes levonorgestrel into the uterus, improves symptoms, and is shown to actually reduce fibroid size. If the Mirena is not suitable, treatment with tranexamic acid is indicated. This is normally taken on the first day of bleeding and is taken for 4 or 5 days during the cycle, and that reduces the amount of blood loss. We can then think about using oral contraceptives, so the combined pill or the progesterone-only pill. These can be used cyclically or continuous, just to reduce the amount of periods this woman is having. If all the above methods have failed, we can think about surgery. So this would be via a uterine artery embolization, where we go in and embolize those bleeding arteries, or a full hysterectomy. So let's move on to the next question. And again, I'll give you a minute.
The poll for this is up now. Feel free to select in your votes. Last 5 seconds. Okay.
Great, thank you for answering. So let's talk a bit about irregular menstrual bleeding. This woman's experiencing irregular bleeding. So irregular cycles are quite common after menarche and pre-menopause. However, new irregular bleeding should be investigated in all cases because we want to exclude things like cervical cancer. Causes of irregular bleeding include infection, hormonal contraception, pregnancy, weight changes, in particular weight loss, polycystic ovarian syndrome, and endometrial hyperplasia. So if we go back to the question there, the most appropriate answer here is a transvaginal ultrasound scan. I'm mindful of the fact that her symptoms may just be because she's approaching menopause. Her age is 50. However, it's worth taking a thorough history here, focusing on what she means by irregular bleeding. Does she mean a lengthening of cycle, which commonly occurs premenstrually, or does she actually have irregular random bleeding, which is more worrisome? A transvaginal ultrasound would allow for visualization of her endometrial and have a good look at her uterus. And what happens in the ultrasound scan is the operator measures the endometrial thickness. Looking at the other answers there, colposcopy would be indicated if this patient had had any kind of abnormal smear tests or if she had an abnormal looking cervix. Again, we want to take a thorough history to check that her smear tests are up to date and if there's any other risk factors for cancer. While this combined oral contraceptive pill is commonly used for regulation of bleeding in younger women, it's not recommended for women over 50 years of age, so that's not an appropriate answer. And while a Mirena coil often reduces blood loss, and in 10 to 30% of women it actually produces amenorrhea, it's important that we rule out pathology first. One of the side effects of a Mirena coil is irregular bleeding. So if we put in a coil, we wouldn't know if we'd made things any better or any worse. And tranexamic acid, as we saw in the last question there, that's indicated for heavy menstrual bleeding and wouldn't be appropriate for this. So let's move on to the next question. And again, you'll get a minute to read the question and submit an answer.
The poll's up for this now as well. Last few seconds. Okay.
Great, thank you for answering. And most of you guys got the correct answer there. That was A, perform a speculum examination. So this young lady's got post-coital bleeding. And the main causes of that are infection, ectropion, polyps, cancer, vulval pathology, or coil displacement. So we'd want to do a speculum examination to see if we can see her coil threads and see if there's any evidence of pathology of the cervix. In all cases of irregular bleeding or postcoital bleeding, we need to visualize the cervix, looking for signs of pathology. When we're doing the speculum examination, we actually have the opportunity there to take swabs for chlamydia and gonorrhea, so there's no need to ask the patient to take these. And we can take the opportunity to see if her coil threads are visible and if there's any signs of that coil moving through the cervical canal. A transabdominal ultrasound scan wouldn't be indicated here. There's not really any evidence that the coil has moved. And if we can see her threads and they look normal, we wouldn't normally do an abdominal ultrasound scan to ascertain the position of the coil. She may well have cervical cancer. That's certainly a cause of postcoital bleeding. This is unlikely in this age group, and performing a basic examination would still be the first port of call here before we do any referral. If we saw any signs of cervical cancer on examination, we certainly would be doing an urgent referral to gynaecology. And looking at E, while ectropion is a likely cause of her postcoital bleeding and possibly the most common cause in this age group, we've got to examine the patient to ascertain this. So let's just have a wee chat about ectropion. You might not have seen ectropion. So this occurs when the columnar epithelium, which is normally inside the cervix, appears outside the cervix at the os. And it's visualized on speculum examination as sort of a bright red halo coming out of the os. And it might bleed if you contact that with a swab when you're taking your STI swabs. It's a benign condition and normally doesn't require any treatment. So move on to the next question.
So polls are up, feel free to put your votes through. Last 5 seconds. Okay.
Wonderful, thank you for answering. So let's talk about dysmenorrhea. So dysmenorrhea, remember, is painful periods. And this is common right at the start of menstruation, so after menarche and before menopause. And we can divide this into primary dysmenorrhea, which is painful periods with no organic cause, and secondary dysmenorrhea is when we've found some underlying cause that's causing the painful periods. We want to rule out underlying causes in this case. So thinking about things like STIs, pelvic inflammatory disease. We want to ask about things like previous pelvic surgery. Is there going to be adhesions, which is a risk factor for endometriosis, and asking if there's ever been any other gynecological issues. So management of dysmenorrhea aims to reduce symptoms. So non-pharmacological methods are pretty helpful. Things like heat packs, warm baths, exercise, and TENS machines. Simple analgesia, so paracetamol and cocodamol. And the next line would be something like mefenamic acid, which is a non-steroidal anti-inflammatory, which is particularly good at controlling menstrual pain. We might also think about starting an oral contraceptive pill, so the combined pill or the progesterone-only pill. And the aim here is to reduce menstrual loss and therefore pain. If the above methods don't work, we can think about a Mirena coil. Mirena coils do reduce bleeding and reduce pain overall. If all the methods don't work, we can normally refer these patients for a diagnostic laparoscopy. And the point of that is to look for endometriosis and possibly treat at the same time. So looking back at the question here, the most appropriate answer, which most of you guys got, was mefenamic acid. She'd already tried paracetamol and ibuprofen, so the next stage is to swap out that ibuprofen for mefenamic acid. A copper IUD, that wouldn't be appropriate. One of the side effects of copper IUDs is heavy and painful bleeding, so that would not be appropriate. And while a contraceptive pill might be useful, it does say in the scenario that she's not keen to take anything hormonal. Codeine phosphate certainly can be useful as a analgesic, but we'd want to try an NSAID first just because it's got less side effects. And diazepam, that's not appropriate. So we'll move on to the next question.
So the poll for this is up now as well. Five more seconds. Any last guesses? Okay.
Thank you for answering. So this lady has premenstrual syndrome. So let's have a wee chat about that. So this is defined as any distressing psychological, physical or behavioural symptoms, and it occurs during the luteal phase. So that's the phase just after ovulation and before menstruation, hence the name premenstrual syndrome. The exact cause is unclear, but it appears to be triggered by ovulation, which induces many changes in the body's responsiveness to hormones and chemical messengers, including things like serotonin. Management of premenstrual syndrome aims to suppress ovulation, as this has been identified as a trigger. So this can be safely achieved using the combined oral contraceptive pill, and this is normally used with no pill-free interval, just to fully suppress ovulation. Transdermal estrogen can be used, but we need to use a progestogen alongside that because we can't have unopposed estrogen. GnRH analogues, they're really used as sort of a last line in terms of premenstrual syndrome because they've got quite bad side effects on bone mineral density. We can also try things like antidepressants, SSRIs, SNRIs, or tricyclics. So looking back at the question here, the most appropriate answer is a combined oral contraceptive pill with no pill-free interval. So checking back with the question here, transdermal estrogen can be used, but it's not usually used first line. We'd normally try a hormonal contraceptive first. And hormonal intrauterine systems, so things like Mirena, they have no systemic effects. So this wouldn't have any effect on her mood or her anxiety, things like that. There's no evidence that Depo-Provera is effective for PMS. And actually one of the side effects of Depo-Provera is mood changes. So we'd actually want to avoid that. Triptorelin, that's one of those GnRH analogues, and it acts to suppress ovarian steroid hormone production, but unfortunately it does have the side effect of bone mineral density reduction, so we tend to save that as a sort of last line treatment of severe cases of PMS. So most of you got the correct answer there. It would be combined oral contraceptive pill with no pill-free interval. So let's move on to the next question.
The polls for this is up now as well. Last few seconds. Okay.
Great, thank you for answering. So this question is asking about hormone replacement therapy, which is a pretty complex topic, and there's over 50 different regimes of hormone replacement therapy, so I'm not going to go into all that. So HRT, it's offered to all women suffering from any menopausal symptoms, so hot flushes, mood swings, vaginal dryness, reduced libido, all these symptoms of menopause. And menopause is caused by the gradual reduction in ovarian function and the reduction in estrogen production. So combined HRT uses both estrogen and progestogen. All of the symptoms of menopause are caused by the lack of estrogen, so the estrogen component alleviates these symptoms. The progestogen component is to prevent unopposed estrogen from causing endometrial hyperplasia. If you just take estrogen with no progestogen, you get endometrial hyperplasia, which causes bleeding. It predisposes you to endometrial cancers. So we need to always remember to provide a progestogen. If the woman's had a hysterectomy for any reason, we don't need to worry about providing a progestogen. So HRT is always tailored to the woman's circumstances. So it's good to take a proper history and see what symptoms are bothering her. For example, if she's just got some vaginal dryness, we can probably alleviate those symptoms with a simple topical estrogen cream. The estrogen component of combined therapy can be oral, vaginal, or transdermal, and the progestogen component can be oral, transdermal, or intrauterine via the use of a Mirena coil. Thinking about the ways that we can give hormone replacement therapy, we must consider when the woman's last period was. If she's still having periods, or if her last period was quite recently, within the last year, we give hormone replacement therapy in a cyclical manner. This means we don't mess with her bleeding pattern. The same dose of estrogen is taken every day, but the progestogen component is taken only on the last 14 days of the cycle, so the woman will still have regular periods. If she's postmenopausal, i.e. it's been a year since her last menstrual period, we can give her continuous HRT, and this is where she gets a fixed daily dose of both the estrogen and the progestogen. So if we go back to the question, she's 51, she's taking HRT because she's got hot flushes. So it sounds as though she needs something that's systemic. It's not vaginal symptoms she's complaining of. It sounds as though her last menstrual period was only 4 months ago. So we're thinking about a sequential or cyclical system. So the correct answer there is an oral sequential combined hormone replacement therapy. Let's just look at the other answers though. An oral continuous combined, that's not appropriate because it's only been 4 months since her last period. Taking a continuous combined HRT at this point would likely induce irregular or erratic bleeding, which might be a problem for her. Estrogen only hormonal replacement therapy, that would be dangerous because we can't give unopposed estrogen. We need to provide some sort of endometrial protection. A Mirena coil would not help with her symptoms. That only contains progesterone and it's only acting locally on the uterus. That wouldn't help with her hot flushes. And a transdermal estrogen only, again, we can't just give this woman estrogen. She has a uterus, so we must protect that. So let's move on to the next question.
Polls are up for this one as well now. Last 5 seconds. Okay, wonderful.
Great, thank you for answering. So most people have answered B, a copper intrauterine device. Thank you for answering. So let's talk about emergency contraception. So emergency contraception is offered to all women who've had unprotected sex and don't want to be pregnant. This can be offered at any day of their menstrual cycle. So there's 2 pills that are normally known as the morning after pill. There's levonorgestrel, or Levenel is the brand name. That's licensed for up to 72 hours following unprotected sexual intercourse. Sorry, I should have said that, oopsie, up to unprotected sexual intercourse. The other pill is ulipristal acetate, or ELA1, and that's licensed for a little bit longer, up to 5 days following unprotected sex. The only other method of emergency contraception is the copper intrauterine device, and that's licensed for insertion up to 5 days following unprotected sex. So the mechanism of action of both of these pills is to delay ovulation. So if the sperm are already inside, if we delay ovulation, we then delay fertilization. Fertilization can't happen. In terms of the copper IUD, its mechanism of action is to release copper into the uterus, which prevents fertilization. Sorry, it prevents implantation. So even if the ovum has been released and fertilized, it cannot implant in the uterus, which is why it's useful for a little bit longer than Levenel. So looking at go back at the question here, she's had unprotected sex approximately 85 hours ago. So in this case, she's not suitable for the levonorgestrel. She's too late for that one, as it's only licensed for up to 120 hours. And she's looking for the most effective contraception. So ulipristal acetate is about 98% effective at preventing pregnancy. The copper IUD is over 99% effective. So in terms of efficacy, the copper IUD is offering her the best protection against getting pregnant. The copper IUD's got the added advantage that it can be left in situ and it can provide long-acting contraception for 5 to 10 years, depending on what device is used. Looking at the other answers there that we might have chosen, while the Mirena does offer effective long-acting contraception, it does not provide emergency contraception, so this would not be appropriate when she's had unprotected sex so recently. Methotrexate is used in the management of ectopic pregnancies and is not indicated for emergency contraception. And the combined hormonal contraceptive pill, that might be good for this woman to go on after she's dealt with this current episode of unprotected sexual intercourse. The combined hormonal pill does not provide emergency contraception, so that's not appropriate. So move on to the next question.
Okay, so the poll is up for this one now as well. Five more seconds. Okay.
Great, thank you for answering. So we've got a 36-year-old woman attending for a routine sexual health screen and she's looking to start the combined oral contraceptive pill, and we're looking for reasons that would render her unsuitable. So let's just have a wee chat about the combined oral contraception. So the primary mechanism of action here is to prevent ovulation. The combined hormonal contraception comes in pills, patches, or a vaginal ring. The pill is traditionally taken as 21 days with a 7-day hormonal-free interval, during which the woman will have a bleed. However, it's now sort of recommended to chat to women about different ways of taking the pill. So continuous use is when the pill is taken continuously with no hormone-free interval. Sometimes women will experience some breakthrough bleeding here. Sometimes they'll have no bleeding. Extended use is when you have less frequent hormone-free intervals. So instead of having a bleed every 21 days, you can have a bleed every 3 months, 4 months, 6 months. We can also shorten the hormone-free interval to just 4 days rather than 7 days. This is useful for women that have quite heavy periods, as it reduces the period of bleeding. And we've got plenty of flexible extended use things. So some women will take the pill continuously until they have a bleed. They'll then take a 3 or 4 day bleed and they'll then go back on their combined pill. So there's lots of different ways to take combined hormonal contraception now. It's not traditional. It's not the 21 days on, 7 days off anymore. There's lots of different ways to take it. And let's talk about, there's lots of reasons why you might be unsuitable for combined hormonal contraception. And the whole reasons behind this is because it increases your risk of venous thromboembolism. So when we're thinking about risk factors, we're thinking about what is the risk factors for having an embolism. Now, the Faculty of Sexual and Reproductive Health issues quite good guidelines and a list of eligibility criteria for all different types of contraception, including combined hormonal. But in terms of this question, I appreciate you guys probably won't know all the ins and outs of this. So I would tackle this question as thinking about risk of blood clots. So what increases your risk of blood clots? Being postpartum certainly increases your risk of blood clots. Being older, smoking, having high blood pressure, having vascular disease, having heart disease, having previously had an embolism. These are all fairly sort of self-explanatory reasons as to why she might be at higher risk of an embolism. You won't need to know the ins and outs of all of this for your exams, but just to think about the reasons behind it. So the reasons behind these contraindications are all to do with risk of embolism. So if we look back at the question here, she is 36 and she's not really disclosed any other history. So which of the following things would render her unsuitable? So the correct answer here is that she used to smoke but stopped 6 months ago. And as you guys are probably aware, stopping smoking doesn't immediately negate all of the risks associated with smoking. So actually the FSRH guidelines say that if you've stopped smoking within the last year, you're still at risk and shouldn't be taking combined hormonal contraception. Looking at the other answers, she gave birth to her first child 6 months ago. Combined hormonal contraception is not recommended 6 weeks after giving birth, but 6 months, your risk is reduced enough to be able to take it. Looking at C, she's due to have minor cosmetic surgery. That's not going to immobilize her, so her risk of thromboembolism is not any higher, so she's fine to still take the pill. She was diagnosed with pregnancy-induced hypertension during her first pregnancy. Yeah, that's making you think maybe she has hypertension, but unless she has hypertension, that's not a contraindication. And a family history of breast cancer, that's not a contraindication for combined hormonal contraception. It's only if she has a personal history of breast cancer or if she's a known carrier of a gene mutation. Because as we know, breast cancer cases are not necessarily familial. There's lots of sporadic cases. So having a family history of breast cancer does not make you unsuitable for a combined pill. I appreciate why a lot of you have put that as the correct answer, but it's only a personal history of breast cancer that would negate your suitability of the combined pill. So the correct answer there is that she used to smoke but stopped 6 months ago. So any smoking over the age of 35 is a big risk factor for thrombus. So we'll move on to, we're nearly there, we'll move on to the next question.
So you can vote with the polls. Should be open for you. Last few seconds. Okay.
Awesome, thank you for answering. So this question is talking about the Fraser guidelines, which you've probably all heard of because most of you got the correct answer. This is a set of criteria that must be met for us as doctors to be able to provide a child less than the age of 16 contraception and sexual health advice without breaking confidentiality. So the guidelines say that she's got the patient has to be sufficiently mature to be able to understand the nature and implications of the treatment. They cannot be persuaded to tell their parents or allow the doctor to tell them. They are likely to begin or continue to have sexual intercourse with or without the treatment. Their physical and mental health is likely to suffer if we don't give them advice or treatment, and the advice or treatment must be in their best interests. So if we look at the answers there, the correct answer there is the girl is likely to have intercourse regardless of whether we provide contraceptive advice. But let's think about the other questions there. Sorry, the other answers there. There's no requirement that she's already sexually active as long as you're satisfied that she's going to have sex regardless of whether or not you give her advice. She doesn't need to attend with anyone else. She can attend alone, with her boyfriend, with anyone else. There's no requirement for that. You do not need to tell a parent or guardian. They don't need to be aware. You've got to make some effort to try and persuade her to tell her parents or a responsible adult, but she doesn't have to. And her partner doesn't have to be the same age as her. However, she's 15, so we would probably want to think about asking her about the age of her partner. We would want to consider the possibility of any sort of abuse, any sort of like elder people that are preying on this young girl. So we would want to ask about the age of her partner, but she says that her boyfriend's the same age and that's not a requirement for the Fraser guidelines. So we'd be happy to provide contraceptive advice to this girl, provided she fulfills all of those criteria. So we're going to move on to the next question. This is the last question, and this is an emergency scenario. It's a bit tricky, but it's based on a real life scenario that I encountered as an FY1. So I'll maybe give you maybe a minute and a half to 2 minutes to answer this question, just so that you can think through it properly. So if that's okay, Julie, just give the guys a wee bit longer to answer this question.
Yeah, that's fine. I'll give them a minute to read and then a minute to answer as well.
Yeah.
We've got a minute to read, have a read through all the obs and bloods as well. Okay, I've just brought up the options so you can select A, B, C, D, or E for this. And I'll give you a bit longer as well. You can go back and have a read over if needs be. Okay, last few seconds. Any last guesses? Feel free to put them through. Love.
Awesome, thank you for answering that. I appreciate that's a tricky question, but I like to always finish on something that's kind of relevant to you working as an FY1 in the not too distant future. So let's dissect this situation. We've got a 45-year-old woman. She's 1 day post-op following what sounds like a pretty big and complicated operation. Sounds like she's had adhesions present, and it sounds like this has been not a straightforward hysterectomy. The crux of the problem is she has pain and she can't pee. So in terms of her observations, she's tachycardic, she's a bit hypotensive, her temperature's fine, her respiratory sats are fine. Looking at her bloods, her hemoglobin's fine, white cell count is high, platelets are high, urine electrolytes are normal, and CRP is high. Looking at those kind of post-op bloods, you will find that post-op patients will have a rise in CRP, platelets, and white cell count, just as an inflammatory response to what we've been doing inside them. So that's not entirely unexpected. So what's happened? So let's dissect the situation. So let's look at the possible answers. So in this situation, you've no idea what's happened. I would look at the answers. Intra-abdominal infection. I don't think this sounds like an infection. She's only 1 day post-op, which is not the prime time for developing infection. In addition, she's not pyrexial, and there's no evidence of sort of peritonitis or pus coming from anywhere. There's no evidence of purulent discharge from the vagina. So I'm happy to rule out abdominal infection. Acute kidney injury, a common post-op problem. However, I don't think it's an acute kidney injury. Her USNEs are normal, and when the nurse had put in a catheter, her urine colour is normal. So I don't think this is an acute kidney injury. She's also on loads of IV fluids, so it'd be unlikely that her kidneys are suffering. Intra-abdominal hemorrhage. This can certainly account for her hypotension, her tachycardia, and is a common post-op problem. But her hemoglobin's normal, and why can't she pee? Ileus, another common post-op problem, especially in complex abdominal surgery like this, where we might have been handling the bowel. However, she's been eating and drinking fine. There's no mention of nausea, no mention of vomiting. And why isn't she peeing? Ileus also wouldn't normally cause hypotension and tachycardia unless it had caused an obstruction or if there was some sort of perforation taking place. So we've ruled out those ones, and the most likely complication to have occurred here is a bladder injury. So it turned out in this patient, in the process of this complex operation, part of her bladder had become adhered to her uterus. So when she had her hysterectomy, part of the bladder had been nicked during the operation, and urine was free flowing into her abdomen. This sort of accounts for the non-blood-stained discharge from her abdominal wound. That's actually urine coming out of her abdominal cavity. Her USNEs are normal because her kidneys are functioning normally. The urine just isn't making its way out of the bladder. And we've put in a catheter. It drains 200 mils of urine. So we've ruled out things like retention. This woman actually ended up going back to theatre, having a further operation, which included gynaecology, general surgery and urology. She spent a couple of days in ITU and was absolutely fine, made a full recovery. So I guess this scenario just sort of teaches you to think about your options, what is wrong with this patient, and if you can rule things out, that's certainly helpful. So most of you guys got to the right answer of bladder injury. However, all of those answers are potentials, and you've got to think about ruling things out when you've no idea what's going on. So well done, guys. We've got to the end of the lecture. I appreciate I went through that pretty rapid, but as Julie said, it will get uploaded onto YouTube and you can pause it, rewind it, whatever you like to be able to go through the answers. So we've covered quite a lot there. I'm going to just have a wee look at the questions and answers and see if I can answer those for you. So I'm being asked, in what situation would you give estrogen alone as HRT for menopause? So let's just go back to that question 1 second. I'm just going to go back to the question on HRT. So I think it was regards to this question. So this was a 51-year-old woman seeking HRT. The question is, in what situation would we give estrogen alone? So we would give estrogen alone if the woman does not have a uterus. The danger of giving estrogen alone is that estrogen causes the endometrium to proliferate and causes bleeding and predisposes you to endometrial cancer. So we do not give unopposed estrogen in any women without a progesterone to protect the endometrium. So even if her periods ended a year ago, we still wouldn't give her just estrogen. Further question asking about how do we sequence HRT, when in the cycle is it given? So normally it's given, estrogen is given as a fixed dose of every day of the cycle, and the progesterone component is given in the last 14 days of the cycle. So it takes a bit of working out of how long the woman's cycle is, when her menstruation is, to work out when to give the progesterone, but it's normally given for 14 days of the cycle and the last 14 days of the cycle. Someone's asking, how does diabetes cause menorrhagia? So diabetes in itself doesn't cause menorrhagia, it's simply a risk factor for menorrhagia. So diabetes is sort of a metabolic syndrome, and menorrhagia is associated with women who are obese, women who have PCOS. It's unclear what the exact relation is. Diabetes doesn't definitely cause menorrhagia, it's simply a risk factor. So definitely something to think about, but not a direct cause. Same for raised BMI and fibroids. So raised BMI is a risk factor for fibroids. And again, it's related to the overall metabolism. Some women are more predisposed to developing obesity, developing PCOS, developing metabolic syndrome. They're all sort of related in ways that we don't quite understand, but raised BMI is a risk factor for fibroids, not a cause. You're correct there. We're being asked about normal palpable uterus. Let's just go back to that question.
Well, we're just going back, the feedback is in the chat as well as a link. So we'd be really grateful if you've got any comments or improvements, if you click on that and you can leave us some feedback there. Thanks a lot.
So the question is, isn't it normal to feel the uterus the size of a satsuma? Yep, you can normally feel a normal uterus on bimanual examination. If you're pushing your fingers down kind of behind the pubic symphysis, you can quite often feel the uterus. And I think a size of a satsuma or a pear is commonly quoted. In this question, we can feel the uterus above the symphysis, which is not normally normal. And if you were writing notes about someone, you wouldn't normally say, I can palpate the uterus unless it was enlarged. You wouldn't normally know that you can feel a normally palpatable uterus, but you're absolutely correct. You can normally feel the uterus, and I think a satsuma or a pear is the common fruit used to describe the size. Let me just go back to the question this relates to. I think it was actually this one. So again, in this question, someone is answering why not endometriosis, as she does mention pain. So the question's asking for the most likely diagnosis. These questions, you've always got to think about what's the most likely. Certainly endometriosis can be causing her symptoms. Endometriosis can cause heavy periods. Endometriosis can cause pain. However, we're thinking about her risk factors. She's overweight and we can palpate her uterus. So it means endometriosis is a less likely diagnosis. It doesn't mean it's not the diagnosis, but the question's asking for the most likely. So that's why I've gone there for fibroids rather than endometriosis. And being asked about the difference between tranexamic acid and mefenamic acid. So yeah, I used to always get confused with these as a student. So tranexamic acid has a more sort of anti-bleeding effect. So that's used in things like menorrhagia. It's also used in A&E for people that are bleeding, as it's an anti-bleeding agent essentially. Mefenamic acid, the main mechanism of action there is anti-inflammatory. So it's more useful for painful periods. I'm not sure if there's an easy way to remember that. I certainly got confused with those as a student as well. Let's go back to the question on premenstrual syndrome. So this question was asking about premenstrual syndrome, and the question here is, would you use the combined hormonal contraceptive therapy as a form of contraception? Yes, if she's taking the combined oral contraceptive pill with no pill-free interval, that certainly functions as a contraceptive. And we wouldn't normally advise someone to just take the COCP in the luteal phase. We'd advise them to take it all the time. If you only take it in the luteal phase, you're unlikely to achieve suppression of ovulation. So we want to be taking it all the time to try and suppress those ovaries right down and stop those surges that are causing her mood swings. And yes, it would function as a contraception. We'd let her know that. I know she says she's not sexually active, but if she's got contraception. Looking at HRT, let's just go back to that question. So thinking about HRT, and the question there is, if you're using transdermal estrogen, in what form would you give progesterone? So we can give that in any form here. We can give it in oral, transdermal, or intrauterine, depending on the woman's circumstances. If she's already taking a pill, we might recommend, a progesterone pill. Intrauterine contraception means that she's protected against endometrial hyperplasia and also has contraception on board. So yeah, we can give it in any form, oral, transdermal, intrauterine. The next question is looking at, is there a risk of ovarian cancer and HRT? Yes, there is. So I'm not sure the exact stats, but there is a minor increased risk of ovarian cancer with HRT. So you've always got to counsel these women carefully. You've got to counsel them about risks and benefits of HRT. The risk of ovarian cancer is small. I think it's about 1 in 1,000 women taking it for 5 years. There'll be one more case of ovarian cancer. So it's not a huge risk, but certainly something to think about. And especially if a woman has a family history of ovarian cancer or is particularly anxious about ovarian cancer, we would want to think about that. Thinking about why combined hormonal contraception can't be given in breast cancer. Let's just go back to that question. So talking about combined hormonal contraception and reasons why people can't take it. So personal history of breast cancer. I'm not sure if you guys have done your sort of general surgery block, but quite often breast cancers are estrogen positive or progesterone positive. You'll hear that being referenced as ER, PR positive in breast cancer. We would want to avoid giving any sort of estrogen in someone who has any breast cancer, just because there is a risk that breast cancer is estrogen receptive, and we then facilitate further spread of a breast cancer. So we'd want to avoid combined hormonal contraception in people that have a personal history of breast cancer. Being asked, let's go back to our emergency question. So in our emergency question, wouldn't bladder injury cause hematuria? Yes, it might, and quite often does, but in this case, absolutely didn't. When the nurse put in the catheter, the urine was completely normal. But we've got to think we're giving her 1,000 mils of fluids per hour and she's only got 200 mils in her bladder. Where is that urine? So yes, bladder injury can cause hematuria, but in this case did not. Again, with this question, pain and distension from ileus cause retention. Yes, pain and distension of the abdomen can indeed cause retention, which is why in the scenario, my first port of call was, we'll pass a catheter, check she's not in retention. And the catheter only passed 200 mils, so that wouldn't be a retention. She'd have much more in her bladder there. But yes, that's certainly the correct thing to do. If you approach this patient, one of the first things you'd want to do is pass a catheter. So you're absolutely right there. Let's just have a wee look. Just going to go back to the question this is referencing. So talking about Fraser guidelines and asking if you would break confidentiality if the boyfriend was much older. Technically the age of consent in this country I think is 13, so technically not breaking consent, but you'd want to try and tease out that information, see who is this boyfriend? Is this boyfriend someone in a position of power? And if you were worried about this woman, this girl of 15 years, you can breach confidentiality in these circumstances. In these cases, it's always on a case-by-case basis. There is no blanket rule for these cases. Usually there's someone in your organisation that you can contact for advice on these cases. There is no blanket rule. If you thought that her boyfriend was maybe 17 and was in a position of power and you were worried, you would want to escalate that. So it's impossible to say if you would break confidentiality or not. It is difficult, but I think if the boyfriend was a lot older, you'd want to probe that much deeper. Let's have a look. Just starting obs and gynae placement, wondering what resource you recommend. So the best resource you can have is the Oxford Handbook of Obstetrics and Gynaecology. It is a fantastic resource. You can download it in PDF format. You usually have to pay for it, but it's well worth it. You can search it and you can have it on your phone. That's where most of the guidelines come from. That's where most of this lecture is from. Other resources that you can use if you're doing any sort of sexual health, the Faculty of Sexual and Reproductive Health, the FSRH, is excellent at providing guidelines. The Royal College of Obstetricians and Gynecologists, the RCOG, also has guidelines on pretty much everything obs and gynae. If you've just started your placement, I would advise you to get as much physical, practical experience as possible. Scrub in on sections, go to theatre. That's where you'll do all of your learning. You can read a book later on. Try and get as much physical, visual experience as you can. Being asked about the women that had gallstones. Let's just have a wee look. Sorry, I'm just going to go back to the question. So looking at this question, someone's asking about the significance of gallstones. No particular significance, to be honest. I just put that in because she's an overweight 44-year-old and those are common people to have gallstones. That doesn't have any particular significance. Thinking about HRT again. Let's go back to the HRT question. So I'm being asked, would you ever give topical estrogen for a dry vagina, and does it have to be balanced with progesterone? So if you were just giving topical estrogen, so you can get estrogen creams, estrogen gels, pessaries for vaginal dryness. If you're just giving it topically, it's not absorbed systemically. It doesn't have those same dangerous effects on the uterus. So you don't need to give a progesterone if you're only using it topically. If you're using it transdermally, however, in form of a patch, that is absorbed systemically and you do need to use progesterone. Excellent question. Asking about family history of breast cancer and starting contraception. Do you do BRCA BRCA gene testing? No, you don't. You don't do BRCA gene testing. BRCA gene testing is only indicated for a separate, if the woman's got lots of family history, if she's got 2 first-degree relatives with breast cancer, she would then go to a geneticist and get BRCA testing. If you're thinking about providing contraception, you wouldn't be going ahead with BRCA testing. That would be a completely separate sort of endeavour. For starting combined continuous HRT, does it require to be 12 months since the last period? That is the guidelines. The guidelines, if you're going to go on continuous HRT, the guidelines say that it's got to be 12 months since your last period. There's a bit of clinical judgment here. If the woman's had regular periods up until a point and now they've suddenly stopped, she's clearly menopausal, you might go ahead and start continuous HRT, but the guidelines certainly say 12 months. And let's just go back to the woman that had unprotected sexual intercourse and was looking for contraception. So I'm being asked there what the time frame of using a copper IUD is. So using a copper IUD that's licensed for up to 5 days following unprotected sexual intercourse. That can be used at any time of the cycle because it prevents implantation. So even if she's had sex and there is sperm in her vagina, if there is an egg sitting there that's been fertilized, the copper IUD will still work, which is why it's so effective, because it makes a toxic environment in the uterus which stops any sort of egg from implanting. So it doesn't matter what time of the cycle you've had a copper IUD put in, as long as it's in within 5 days, it will prevent pregnancy. That's why it's so effective. Asking what else gives you a palpable uterus. So fibroids is certainly the most common thing that will give you a palpable uterus. Pregnancy being the next most common. Other things that cause a palpable uterus, some sort of uterine pathology. So if you had endometrial hyperplasia, if you had endometrial cancer, if you had bad cervical cancer that had spread far, you can have a palpable uterus. Even some sort of types of bowel cancer can cause a palpable uterus, just as the bowel pushes the uterus further forward. But certainly fibroids and pregnancy are my top 2 causes of a palpable uterus. And I think that's probably all the ones I'm going to answer just now. There's some quite niche questions about doubling up on combined pills and mini pills. That's really quite niche, and you definitely do not need to know that for your finals.
Thank you very much. Thanks so much, Dr. Miller. Thanks. That's been really, really helpful. I think it's always good just to have lots of SBAs, and you've explained them also really, really well. I think there's been a few times people have asked about recording, so we try and get them up as soon as possible. Sometimes it can take up to a week, so just bear with us on that. But you can find them in 2 places, hopefully on the Study Hub website. You need to make an account, but that's all free. You can log in and then find it in past sessions, or I'll also send it to Yazin, who was here at the start, and he'll put it up on the Quesmed YouTube site, which he was going through as well. So hopefully you'll be able to find it there. If there are any issues, you can email like hello@Study Hub, or there's a Quesmed email as well on the screen, I think, or at the start there was. But hopefully that should be all okay. So all the best to everyone. Best wishes from me here at Study Hub.
Thank you, guys.
Thanks very much for Samantha as well. That's been. Hope you all have a lovely evening. I'll end it here, and yeah, one last push as well. If you do have any feedback, you can fill out the form. That would be really helpful. You will also get entered into the Study Hub prize quiz there, as prize draw as well there. So that would be great. Thanks a lot, everyone, and have a lovely week. Bye-bye.
Bye.